So our next session is transforming the health, safety, and performance of Ontario's workforce through field research and advanced technologies. And to do this presentation, we have today Dr. Amin Yazdani. He's the president of the Canadian Institute of Safety, Wellness, and Performance. He's a PhD in kinesiology, and his research focuses on preventing workplace injuries and enhancing job accessibility for diverse workforces. And partnering up with him is Marcus Young, PhD. He's a senior director in research at CISWP. And Dr. Young holds a PhD in kinesiology from the University of Waterloo and is a board-certified professional economist. And his research focuses on the etiology of work-related MSK disorders, exposure to fatigue, and development of prevention strategies and intervention to mitigate injury risk. So, with us, round of applause, please welcome our friends presenters. We'll see you. Thank you.
Good afternoon. I hope that's too loud from here. I hope it's not too loud. Good afternoon. I hope you enjoyed the coffee. I think I had the pleasure of having 5 coffees and no any donuts, but a lot of coffee today. So I'll be talking about some of the work that we do at the Institute and that I think is groundbreaking and I think is making a significant impact. I'll walk you through a little bit of a journey and information about the Institute, and then my colleague, Dr. Young, is going to be talking about some of the initiatives that we have funded by WSIB and WorkSafe Ontario Fund. And I'll come back at the end to talk about one of the other initiatives. To give you kind of a little bit of background about the Institute, I think I have to go down like that. Okay, perfect. We are, I would say, the only applied research institute in Canada that conducts field research. And that's important. I emphasize on field research because, I believe that health and safety research needs to be done where work happens. And the approach we're taking really complements the whole system. It brings everybody together. It taps into the knowledge translational research, theory, and then understanding how things happen in the field, trying to really understand the challenges that the workforce face and provide solutions that they are applicable and they can meaningfully help prevent injuries. We have a significant process that involves collaboration with workers, with employers, with the whole system in trying to really inform the work that the Institute does and the data that we collect. We were funded in 2019. We were based at Conestoga College in Cambridge. Conestoga College is the largest skill training provider in Ontario and in Canada, one of the largest in Canada. And we naturally build a lot of research into skill trades. We conducted an extensive research early on, looking at identifying the curricula training gaps when it comes to health and safety, utilizing WSIB data. We looked at 144 job titles in a skill trades, and we tried to understand how we can use the data to then inform practice, inform training. And we found significant gaps when it comes to MSD, mental health, workplace violence, and harassment. So basically, training providers, that they provide training to skilled trade workers, they are using the curricula standard in which the curricula on health and safety side does not really address the challenges that organizations face, that they do not drive the training to the point that would help prevent those injuries. Following that work, we've received a significant amount of funding from Tri-Council agencies. We received one of the only most advanced comprehensive research grants from Canada Foundation for Innovation to build 2 labs at Conestoga College, a skilled trade campus. One was a skilled trade training lab focused on health and safety called a START lab, and another one looking at addressing accessibility and job accessibility in the skilled trades called a STRIDE lab. And the unique aspect of that was that these labs were within the skilled trade campus, in which, again, 5,000 apprentices and trainees attend this school to receive the training, and we were there to kind of get them into the labs and provide them with health and safety training and recruit them for our research. And that, again, was a very unique model back then when we were implementing that at the college. Earlier this year, CISWP has grown. We received funding from WSIB about a year ago to launch our mobile labs initiative, and the institute became independent earlier this year, so we become a not-for-profit applied research institute that focuses on, again, as I said, field applied research. If I want to summarize the work we do, we work with actual workers in actual work sites, looking at actual conditions. And that is very important because rather than making assumptions, we're going to be looking at real conditions in which workers are experiencing, using advanced technologies, wearable sensors, trying to collect objective data while the workers perform their work in actual work sites. Researchers, they wake up at the same time as a construction worker. They are boots on the ground researchers. They go to the job sites. They go put the sensors on workers. They collect a lot of data during the work shift. At the end of the shift, they take up the sensor, they upload the data, and then our data analysis team will work on analyzing the data and making the data meaningful. The initiatives that are funded by WSIB and WorkSafe Ontario Fund, they are very unique initiatives in which transforms how we understand jobs, how we understand our workers, and how we can meaningfully prevent workplace injuries and disabilities. They provide a value as the comprehensive data infrastructure that everybody can benefit from. I was listening to a presentation about the Pain Institute. The individuals within the return to work and disability case managers, health and safety professionals, training providers, they all can benefit from the data that's being collected as a data infrastructure that can again address the challenges that workers face, would complement the system very well, provide that rich data set that would kind of meaningfully inform practice. We launched the DOES and Mosaic mobile labs earlier, December 15, 2025, at the job site in Toronto. So far, we've reached across the province, from Timmins to Thunder Bay to London to Ottawa to Renfrew County to Cochrane County. Again, our researchers are across Ontario collecting data as we speak. Our mobile labs, currently 3, they're all fully booked within the next few months, and that again shows and demonstrates a significant appetite for that type of work. Phase 1 of our partnership focused on construction and paramedics, and we're hoping to expand that to other sectors very soon, and focus on 3 main initiatives in which Dr. Young will come in here in a moment, and we'll walk you through some of the work that we're doing through that partnership with WSIB and WorkSafe Ontario Fund. Thanks.
Great. Yeah, thanks, Dr. Yazdani. Again, my name is Marcus Young. I'm the Senior Director of Research at the Institute. I think Dr. Yazdani alluded to our 2030 vision of better data, safer work. And what that means to us is that I think we have a great surveillance system when it comes to injury with regards to the WSIB injury statistic data set. But what we do lack is workplace exposure and demand information about what people actually do on those jobs. Really the core of the type of information that we're trying to develop, the data set that we're developing, is to better complement what's existing within Ontario. So we can actually make better meaning of existing data so that we can effectively prevent injuries and illnesses together. Oops, wrong way. It's not really human factor-esque, this little pointer here. So our first initiative is called the Database of Occupation-Specific Exposures, or DOSE. And essentially, this will be a source of workplace exposure data by collecting biophysical information from workers using wearable sensors while they perform their jobs at their actual work sites. Our approach is not just focused on the ergonomic physical exposures, but also the work environmental, as well as the cognitive and neurophysiological. This is important because we traditionally siloed this information out. Now, being able to collect everything in tandem allows us to understand the possible interactions of these different dimensions of exposure demand information and see how they may interact and how they may contribute to any type of injury or illness that arises in workplaces. So the way that we do this is by assigning these exposures and demand data to each task performed under each job assigned to each NOC code. And the reason why we do this is that it allows us to work together more internationally by connecting our NOC codes to another country's occupational classification codes so that we can make better use of this data and make more of a global impact. This is the nitty-gritty of how we collect our information. Again, we use many different types of wearable sensors that reflect the physical, the cognitive, and the work environmental demands of what people do or what people are exposed to. But our work sampling approach is based off of the existing science. Unfortunately, it's a bit nebulous in terms of how often, how much we collect. But based off of the state-of-the-art knowledge, we can say that a minimum of 300 observations across multiple workers for each unique job, utilizing full work shifts over multiple work days over a week, while taking into consideration materials, equipment, tools, geographic location, as well as the type of work. At the end of the day, we'll be collecting all this information. We'll be conducting some bootstrapping analysis to better determine the actual sample size in which we can fully trust that our data is generalizable to each NOC code. Also on those sites, we'll capture self-reported psychosocial safety, perceptions of organizational factors, worker demographics, as well as injury symptoms using validated instruments, as well as their own self-reported job demands. So a very comprehensive approach in terms of using objective, instrumented, direct technical measures, as well as self-reported measures from the workers themselves. So this is just an example of when we're on a data collection site, on the work site, we are conducting two levels of analysis, either observing individuals as they perform their tasks and notating the tasks and duties that they perform. When available, we'll be able to actually collect video and run this analysis post hoc. And below here, we also have an example of some of the measures that we collect. And what we end up doing is clustering or categorizing these types of biophysical measurements into the respective tasks and duties that people perform. And we do this continuously. As I mentioned, one of our approaches is to collect for full work shifts. So here's just an example of some accelerometry data. So it's a measurement of shoulder posture as an example, and how that changes over a workday for multiple tasks that a person might perform. So far, we've collected over 600 workdays, equivalent workdays of data, amongst almost 300 participants. So these are actual workers, again, in construction and paramedicine. As Dr. Yazdani described, we have these mobile labs that allows us to go across Ontario so that we can make sure that the actual job exposures, task exposures that we do collect is not just representative of what you would find in Southern Ontario, but also what you would find in Northern Ontario, in which they may be using different types of materials and different techniques, and therefore different types of demands and exposures that they may face. So we've been pretty fortunate in collecting all this information, and we foresee a lot of data collection in the next many, many years. At the end of the day, we're developing what we call a task exposure matrix. A task exposure matrix is essentially a measure of the frequency, duration, or severity level of particular workforce factors related to specific tasks within a job. And from here, we can actually aggregate at the task level all the types of exposures and demands and cluster that into particular duties. And through time-weighted approaches, as an example, we can calculate an actual exposure or demand value for the job itself. And that allows us to make comparisons across multiple jobs. So just a key takeaway of DOSE, essentially it's one of the world's first comprehensive databases of task exposures. Again, it's not just ergonomic or physical exposures, but it's also the neurosensory and cognitive, as well as the environmental. And this is based off of direct measurement. This enables us to develop both job exposure matrices and task exposure matrices, which we will be able to use to estimate current and past exposures when retrospective collection of direct measurement is impossible. And this is important for occupational epidemiology research when we want to study the effect of exposures on any health condition, including the impact of known and suspected markers of workplace vulnerability. This enables us to reinvestigate existing risk threshold levels. And we do this by optimizing the exposure and disease associations, which might lead to more effective risk assessment tools. And it might also assist us in prioritizing high-risk jobs and tasks for intervention. DOSE will also inform decision-making when it comes to injury claims adjudication. So it'll provide some information about what people are actually exposed to, and we can then use that information to better determine whether a particular injury is due to that said job that that person was in, and also support more effective return to work. And ultimately, because it allows us to collaborate with other research groups, both here in Canada and globally, we hope to open avenues of research in the prevention of workplace injuries and illnesses, but ultimately support businesses based off of evidence using direct technical measurements. It's not just self-report and not just expert-rated, but actual direct technical objective measurements. Attached to DOSE is our second initiative, and this is called Safe Worksite. And we wanted to make sure that for all the partners that we worked with, collaborated with, for every site, that we can give something back immediately. And this is through information about the jobs that we studied for that partner, or it's through supporting their decision-making when it comes to challenges they may face when it comes to occupational health and safety. So I'm going to run through two examples and really focus on one of them that really demonstrates, again, our Better Data, Safer Work initiative, but also as an example of the tools that we can immediately provide to businesses and organizations to ultimately support their decision-making. So as an example, we've been working with several partners in the scaffolding industry, and they were really interested in the ramifications of different hammer designs and different hammer types on the injury risk or potential injury risk of their upper extremities, so their shoulders and hands. And what we did was we brought this back into our labs. We deploy what we call a field to lab to field approach. So we take all that information and simulate that in the lab, have people use these hammers and conduct really stringent, rigorous biomechanical studies. And this will allow us to bring our findings back into the field so that we can ensure that our evidence generated in the lab can be practically and can effectively implemented by businesses themselves. So we've been conducting some studies, we're developing tools on the basis of our findings so that we can then, again, support businesses when it comes to selecting better tools and equipment that will minimize their risk of injury. I'll give you a more deeper example with paramedic organizations that we've been working with for the last several years. Some of the organizations in Ontario, both urban and rural, large and small, have approached us during this process, and they came to us to say, well, a lot of our paramedics are excessively tired, they're fatigued. And this is manifesting into both patient quality care concerns. They're committing higher errors, higher mistakes when it comes to patient quality care. And also, as we know, fatigue is related to both long-term and short-term outcomes, such as musculoskeletal disorders, as well as burnout and future attrition of that workforce from those careers. Fortunately, CISWP has co-developed a fatigue risk management standard back in 2019 with the Canadian Standards Association Group. And without going into detail with this standard, what was quite unique about this was that we took an integrative approach when it comes to fatigue. So it's not just about sleep, but it's about the physical manifestations, the cognitive manifestations, and taking more of a systematic approach to address all forms and all types of fatigue that first responders might experience. So having said that, when generating the evidence in developing the standard, we explored, well, what was out there when it comes to the literature? What does the science tell us? And what we do know is that when it comes to the types of factors related to paramedic fatigue, we can really group them into three categories. That being the type of tasks or workload related aspects of what paramedics perform and do. Their personal characteristics, so worker demographics, age, sex, BMI, as well as more of the organizational-based factors such as shift schedules or the role of that paramedic for that given shift, or whether they're working in a rural or urban service. So as you know, because fatigue is this really nebulous, big thing, no one really can define it properly. That's why we took this integrative approach. We also explored, well, how do you even measure fatigue? How do you even assess the risk of fatigue? And as you imagine, there's just so many types of measurements out there. But what we did realize was that despite the fact that there were many types of measurements and measurement tools, there's nothing that's really job or task specific, and nothing that really predicts that level of severity or probability of experiencing fatigue after a work day. So how do you approach an organization like a paramedic service and tell them, well, if you want to assess fatigue, there's measurements out there, but nothing really works for you. So that really excited us when it comes to our worksite initiative in developing maybe perhaps a better risk assessment tool for paramedic organizations. So I'll go through with you in the next few slides the data that helped inform the tool itself, and then we'll just give an example at the end of how that tool might be used in action. So as I mentioned, many risk factors, but again, we don't know which of these risk factors are most associated with, as an example, poor sleep or physical fatigue or mental fatigue. In our example here, we'll focus on sleep-related fatigue. We don't know how these factors might interact. So how does the personal, the workload, and the work organizational factors interact with one another? And as I mentioned before, there's no paramedic-specific risk assessment tool. So again, this inspired us to conduct this cohort fatigue study where we worked alongside large urban and rural Ontario paramedic services, and we conducted what we call a actigraphy study. So I'm not sure if anyone has used actigraphy before, but essentially they're wearable devices, they're actual watches that track activities, and we can use that information to understand the quality and duration of sleep that a worker, in this case a paramedic, will experience at the end of their shift. For this study, we collect over 28 days of data, which covers a full rotating or straight day shift schedule. And we actually did this 3 times within a year, approximately 3 to 4 months apart. What's unique about this study is that while we have this great outcome information about how or the level of fatigue that a paramedic experiences at the end of the shift, but we need some added information about what people actually did. So we utilized ambulance call report data, which is mandated and required in Ontario for every paramedic to fill out. So it has to be very accurate, but it basically explains the types of calls, the types of interventions, the drive time, the arrival time, everything about what a paramedic experiences for every shift. And also we asked paramedics to provide some information to us through self-report of the quality of sleep, but also some demographic information. So as I mentioned, it's a cohort study over a full year. We've been doing this, again, with urban and rural paramedic services, but this is actually an ongoing initiative, and we have several partners that we are continuously working with for the foreseeable future on this initiative. So as I mentioned, actigraphy watches, wearable devices, they're wrist-worn. We can then calculate sleep-wake cycles, sleep duration, and other sleep parameters using validated algorithms. It's a low-cost tool. It's suitable for field measurement, and it's quite comparable when it comes to gold standard measurements, such as PSG, or polysomnography. So that's a mouthful. And again, it's a great objective measure when compared to kind of self-reported measures that some studies have used in the past to better determine or to estimate the levels of sleep amongst the population. So our predictor variables are factors related to those 3 categories I described before. But what is that outcome variable? So we defined our outcome variable using that sleep watch information, and we define a fatigue case or a sleep event, or bad sleep event, as a night of sleep that was less than 85% sleep efficiency, experienced more than 7 average awakenings per night, and for each awakening lasted longer than 5 minutes. So this actually reflects both sleep quality and sleep duration deficits. And in many ways, it's a very conservative definition, given the fact that it has to hit all 3 parameters to be defined as a sleep case. Without going into the weeds here, we conducted multivariable logistic regression models, and we conducted interaction models as well. And this allowed us to study the potential association between these factors and a sleep-related event. So again, this is the data that helped inform the model or the tool that we gave to our partners at the end of the day. But as you can see here, we did find in our multivariable logistic regression models that there were variables across all 3 categories that were related to a bad night of sleep. And we did find an interaction effect. So as I described there, 3 different categories were associated with the likelihood of experiencing a poor sleep episode. So therefore, we wanted to ensure that all 3 categories are indeed represented within the tool that we actually developed for those services. Some of the personal characteristics, such as age and sex, were associated with poor sleep. So as an example, compared to males, females had 74% lower odds of experiencing a poor sleep episode after we adjusted for all other covariates. And with every increase in age by years, the odds also decreased by 18%. So that was a quite unique finding there. We found that job function, so what the paramedic actually did on that day, so whether they were the driver or they were the attendant, so basically the attending paramedic within the patient compartment. Compared to attendants, those in the patient compartment exhibited 5.3 times higher odds of experiencing a poor sleep episode. And again, and perhaps more importantly for us, we found that workload exposures and demands, such as call complexity, which we defined as the number of clinical interventions that was performed per call, was also associated with a poor sleep episode. So for each additional performed intervention, the odds increased by 24%. Surprisingly, I didn't mention anything about shift schedules, which is funny because you would think, well, the current literature actually says, well, shift schedules is what's determining a bad night of sleep. But we didn't find that. What indeed we did find was what people were actually doing within their day-to-day work that's related to a bad night of sleep. We did find a significant interaction between age and call complexity, where higher workload intensity was associated with predicted probabilities of poor sleep across all ages, but that relationship was more pronounced with younger paramedics and attenuated with increasing age. So this is lots of information, lots of data, doesn't mean anything to an organization really until we actually make use of it. So our current understanding is that all factors should be represented within a tool. We wanted to make sure that any information that flows through this tool is available to a service, so they don't have to input anything, they don't have to calculate anything. That information is readily available to them on a day-to-day basis. And we also wanted to make sure that it's integrable with paramedic-specific and shift-level data. So the way in our approach for this tool is through machine learning models, where we used random forest as our primary model. This allows us to grow this data set because, as I mentioned before, we're currently collecting more data from different services and allows us to really create a more robust tool at the end of the day. The inputs of this tool is those personal information, the call report information data, and again, it's consistent with both the language and format of information available to the actual services themselves. So this is not me clicking through, I'm not this quick, but essentially this is just an example in the manual way of inputting both the call report data and the personal data on a per paramedic basis. And at the end of the day, we'll be able to provide a risk score for that paramedic and also track that historically over many, many days and to see how that might change over the course of multiple days. Again, it's providing organizations with perhaps a red flag as to when they can intervene and what they can do to intervene to reduce, let's say, the effect of a day-to-day shift for that paramedic. It might also allow paramedic organizations to consider what they can do after a call that's particularly demanding to minimize that risk on that paramedic. So just to sum up, that study, that worksite initiative, that project that we've worked with our paramedic partners, it's, again, comes down to better data, safer work. I think we can really achieve a lot of great things by utilizing existing data sources and complementing that with new generated data that we are currently doing with our DOSE initiative. Again, collecting technical, objective measurements of what people do, and use that workplace surveillance information to better understand why injuries happen, what new risk assessment tools can be created, and there we can then better predict injuries and also develop better and more targeted solutions to reduce and prevent those injuries before they actually occur. So I'm going to hand this back over to Dr. Yazdani, who would describe our third initiative.
Thank you. I hope you're not fatigued. 10 more minutes and let you out. A third initiative funded by the WSIB and WorkSafe Ontario Fund focuses on a significant data gap that exists in Canada, and we're so proud of taking that leadership in that front. Everything we use, the cars we drive, the PPEs that workers use, the jackets, the suits, everything that we interact with in the environment, they are based on some underlying anthropometry norms or data. In Canada, unfortunately, we do not have an anthropometry database. There are some general population databases available from Asian population or from American general population, or some military data from the US military. But those are dated back 1970s, 1960s, updated a couple times later years. But again, there is nothing based on the Canadian data set. And those data that are available, they're mainly manually measured, or again, as I recently mentioned, the updates are using 3D scanners to provide some of those data, very limited number of body segments. So we wanted to create something comprehensive for Canada, and we wanted to kind of really add this a few things. We talked about job accessibility, we talked about ergonomic design, we're talking about prevention through design. We wanted to kind of create something unique that will potentially, in my opinion, will shape product design, tool design, equipment design, PPE design for the generations of Canadians and beyond. The inclusive design of PPE and equipment, they have some implications in the context of health and safety I'm talking right now. One is about prevention of injuries. We talked about engineering control being one of the higher levels within the hierarchy of control. But really, if you want to design a new work, or if you want to design a new workstation, you want to redesign it, you got to base this based on some of the data that is not available. We want to remove barriers for equity deserving groups. We want to broaden injury prevention ecosystem. We wanted to kind of address some of the basic issues that prevent individuals from diverse backgrounds to get into some of the high-paying jobs, including trades, including healthcare. Again, I talked about this. There is not Canadian population data. They do not consider multiple body measurements parameters. They do not consider all the other information that will potentially help us to understand the anthropometry and the body dimensions data of the Canadian workforce. So the Mosaic database, or multi-bit occupational specific anthropometry database, is the only of its kind in Canada that uses the technology, which I explained in a moment, that will, again, as I said, when it's developed, is going to be a source of information internationally for anyone that wants to make a product for working population. We do have a mobile app, again, funded by WSIB and WorkSafe Ontario Fund. It deploys across the province. We go to job sites, we go to training centers. We put in this 4D body scanning technology. We are the only one in Canada that has both lab-based and portable 4D body scan technology. It would take us about 3 hours to set it up in any sizable room. We'll be able to get people in, do a quick scan. As a 4D scan, it will create an avatar of each worker. The avatar spits out 100 measurements, body segment measurements from each worker on a static posture. The beauty of the equipment, which I explain in a moment, it allows us to collect data in dynamic movement as well, which I explain why this is important, why this is unique. In addition to body dimensions, we collect foot scanning. We get a 3D model of a foot. We have hand scan. We collect body composition data. We collect a lot of demographic information. We also collect pain and discomfort data from each worker. And again, it's job specific. It gives us the 365-degree view of each worker. So the dose was about understanding the jobs. Mosaic is about understanding workers. And what is the capacity of workers? We're collecting a strength measurement from workers. So we understand what is the capacity of the workers performing that plumbing job, electrical job, nursing, so on. Again, it's important to highlight this is job-specific database. Again, this is very unique because then we can be more targeted when we come to providing recommendations. The significant asset for those focusing on return to work, disability management, as well as provide information to workers of how they can actually prepare themselves for the jobs ahead. It serves as a source of information for manufacturers of PPE, tools and equipment to make better products for the Canadian workforce. We have about 1,000 data from 1,000 workers that we've collected across different sectors and is growing. We're adding a lot more data. And again, this is an example of a static data that is collected through the system. We do have permission from this gentleman here. He's a boilermaker that allowed us to kind of share his face. We mask all the data. We go through significant REB and confidentiality. But as you see here on the right side, these are the body segments, body dimensions that we collect from each worker. On the dynamic, and that's important because usually when you wear a PPE, when you're interacting with things in your car even, you're not in a static posture. You're interacting. You want to reach. We wanted to collect the data in dynamic posture. So this technology allows us to select 19 body segments that we are interested, and we collect most frequently used postures, and we collect data in a dynamic movement because we want to understand what are the requirements, what are the data that is needed to design PPE, to really redefine reach envelopes if you're looking at designing workstation and work sites. So we're creating a catalog of body scans of a patient-specific simulated task. Again, this is very, very important for design of tools and equipment. I do not know why this is not playing, but basically what it does as the worker performs the job, we'll be able to, can you guys play that video if that's possible from your end? So what it does, like one of the things we were hearing from paramedics was about this pan stance that they have to do when they are actually lifting a patient. And this is a significant issue for many of them when we talk to them about the issues that they have with their PPE and their uniforms. And then what happened is that the fabrics that they use in these uniforms are not unified. Each service, they have their own procurement process, they have their own suppliers. So we wanted to kind of understand, how we can kind of provide this data to these manufacturers, to these designers, as stretcher designers, ambulance designers, to be able to kind of better create solutions. Yeah, can you play that? Well, it's not. So anyway, what it does is that kind of shows that squatting posture that the paramedic needs to perform when they're lifting a stretcher, and then you can see here on that graph here that we can actually see the changes in body dimensions and body segments, and you can again select, thank you. You can select that body segment that you're interested in looking at the data. We do have that in demonstration on the right. We get all workers to wear a compression shirt and compression short. Then there's a consistency across the board of every worker. We collect data across the province. They're using the same outfit. But what it does is really help us demonstrate and provide a rich data set that everybody will be looking for years to come. Again, once this is public, we're happy to announce that in the next few months we'll be publishing the first level of the data to the public. We're not going to be providing the 4D scans because there are confidentiality issues around this, but the aggregated data, we're going to be entering into data sharing agreements with anybody that might be using this data in future for any product development as well. But what it does really would provide a source of rich information for anyone that wants to make any product to then use Canadian job-specific data to make products for Canadian workers. We've been again across the province. The Mosaic mobile labs are booked into fall now. Again, as I said, we get into the job sites and we'll be able to kind of start collecting data, and the support has been tremendous. It would take about 20 minutes to 30 minutes per worker to go through the full protocol. But again, as I said, it is the rich data set that we've been developing. This is just shows a little bit of a kind of a foot data that we collect. Again, 37 measurements from a foot plus a 3D model of a foot. That again is important for foot design. For those that they even study some aspect of the impact of different footwear, and that would have any impact on other health conditions. Body composition data, again, we collect I don't know, over 20 plus metrics into this body composition data. Again, it serves as a main for future research in that area, and really to help us really understand the other effects of different body composition and health outcomes, because we're collecting a lot of self-report health outcome as well. This is phase one. As I mentioned, we're going to be providing aggregated level data very soon through a publicly accessible platform. Again, that's level 1 data. That is aggregated data. But again, you'll be able to go into this database, you go in and search the job title that you're interested in, and then it spits out the 100 measurements at the 25 percentile, 50 percentile. You can go and select what type of data you're interested in, male, female, and that would kind of give you the avatars you need and also the data you need to then be able to develop any products that you're interested in. Again, it will support manufacturers of PPE, tools, equipment, and work environments. It will help OSH practitioners, researchers, again, return to work and disability management coordinators and be able to kind of help advance the prevention of injuries across Ontario and beyond. We are hoping that we'll be soon launching these initiatives, those say Foresight and Mosaic to other sectors. Is going to be a lot of work ahead of us. We extend our request to anyone that would be interested in partnering with us to support these initiatives. Please reach out. We'll be happy to have a conversation and see how our researchers can come to your job sites and be able to build a partnership and be able to kind of address your problems, help contribute to the data set that would help potentially prevent injuries in Ontario and Canada. Thank you so much.